Welcome to the LowCarbMD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. Gosh, this is a really cool one. I have to not be jealous of my partner in crime over here. Tro Kalayjian, this guy from New York, the loudmouth guy who I took a chance on, like saying, this guy is like out there. He's been banned fewer times than me. I don't know what's going on, but Tro, congratulations, man. I'm super stoked about the study you have, and you have your whole team here to talk about it. And for the record, I wanted to do this podcast because I think it's really, really important. So Tro, working miracles, man.
So let's just, I'll catch everybody up to speed very quickly. Really, nothing happens in isolation. So you've been a mentor to me. Nina Teitschultz has been a mentor to me. David Ludwig and Eric Westman have all been mentors to me. And, we have a clinic here in New York. Yes, you're right, I'm loudmouth, but, we're trying to really help people and change the way we provide metabolic care. And, a pretty large corporation came to us and said, can you help bring a metabolic health wellness program to our employees? And we rose to the challenge. Our team is awesome. In fact, I have one of our team members here, Amy Eiges, our program director. We also have Brian Wiley, our office manager, Taline, our medical assistants, Tori, Myra, who went off to medical school, and Esther, who's now likely going to PA school. So we have a whole team here. This was a cool project. We knew we had an impact on these people's lives in this employee wellness program. And I needed help because, we were just joking about this on the air that, doctors aren't really good with numbers, except we have two doctors here who are really, really good with numbers. And I went to Nick and basically begged him. I'm like, Nick, I know you're in med school, but he's finished his PhD, by the way, if you don't know Nick Norwitz over
at Harvard, though. It's not that hard there.
Yeah, so he's in Harvard Medical School. I'm like, hey, look, if you have time for this, I'd love for you to take it on. And he rose up. He's like, I'm happy to help. And so we, it was challenging. And then, of course, he brought on Dr. Adrian Soto, who we worked on another project before all together. So we all kind of knew each other. And, the magic really started with Nick, just like with this last project we worked on with the lean mass hyperresponders. Once Nick touches it, it's like becomes something else. So maybe I'll let Nick talk about.
Yeah, let's have Nick. Nick, welcome, man. Give us the lowdown on all this, the backstory on all this stuff.
Thanks. Yeah.
Nick Norwitz, everyone.
Obviously, all the legwork here goes, props to Tro and Amy who carried this out. So I was all, post data collection, but Tro came to me and is like, I have this really interesting project I'm working on. We have some patients who are having incredible results. Would you, mind taking a look at the data? Do you think it'd be publishable? And I pretty much immediately said yes, but then immediately upon looking at the data, got pretty excited and decided, that this is not only, noteworthy, but absolutely publishable and would make a contribution to the literature, because what he's doing is I just think really fantastic. But I'll stop teasing it and actually say what he did and what the data say. Basically, Tro's clinic was approached by a large manufacturing company. I think they have 5,000 employees, Tro? Something like that?
Something between 3,000 and 5,000. I think it's something, maybe correct me if I'm wrong. It's not a big company.
Yeah, and they're self-insured, and so they went to Tro and kind of asked, we're interested in making a metabolic wellness program to improve our employees' health. So with that in mind, and Tro can tell you more about the approach, Tro and Amy, about exactly what they did, but it was, really focused on low carb, intermittent fasting, CGMs, education technology, the app you have for your clinic, and you ended up enrolling a dozen people with pre-diabetes or diabetes and class 2 or 3 obesity. People that were really suffering, people that were hard to reach, people probably that had tried and failed a lot of other dietary approaches in the past, mean BMI was pretty astonishingly high. It was 48.3. So people know obesity cutoff by BMI is 30. Class 2 obesity is 35. Class 3 obesity, which used to be called morbid obesity, not a term that's used anymore, is 40. Mean BMI in this group is 48.3. These are people that really struggle with their weight and were, for the most part, pre-diabetic or diabetic. And using this approach, I'll just kind of get right to the chase, because a lot of you probably have already seen the beautiful graphical abstract that Tro and his team put together. Every single participant in the study, including the two who had to drop out for various reasons. One had family troubles, another one had termination of employment. But all participants lost a substantial amount of weight. Everybody lost at least 15 pounds, and mean weight loss was 38 pounds, which is pretty astonishing, 38.4 pounds at 6 months. So this is an ongoing project, which I find really exciting. And to have 100% weight loss, 100% of participants losing weight in that much weight, a range of 15 to 58 pounds, and mean weight loss 38 alone is astonishing. But I don't even think that's the most exciting thing about the data. There were substantial reductions in HbA1c, a measure of average blood glucose. Mean HbA1c reduction was 1.1%, and to clarify, because apparently it needs clarification based on Twitter responses, 1.1%, percent is the unit. And Adrian can correct me on the exact data, but I think, Adrian, you were saying like 1.1% mean reduction is like the 95th percentile for most diabetes drugs. So this is like, go ahead.
Yeah, not exactly the percentile.
Just so people know, Dr. Adrian Soto is a big part of the team here.
Sure. I mean, just to clarify that very quickly, actually, I typically teach that the most important statistical marker you need to look at every time you're reading a paper is the confidence interval, and not necessarily the p-value. And the confidence interval is basically telling you what's the span, what's the spectrum within a specific number you're interested in falls on. So this is important because someone was mentioning that, well, 1.1% is not a lot. It is a lot, because it is a lot if you take into consideration, for example, that most diabetes drugs, the average effect they have, in these cases would be what falls exactly in the middle within this confidence interval span, is 0.5%. And 1.1% is the most, you could say, extreme, but still reasonable estimation of the actual size of their effect. So this means that you are the upper limit of your confidence for what's the effect of diabetes drugs on HbA1c, the upper limit, the most extreme, but still reasonable estimation for that number is 1.1. So that really contrasts with a mean change of 1.1. Because if you then use an apples to apples approach, well, what's the upper 95 confidence interval limit for this data? Well, it's not 1.1, of course, that's the mean, it's 3.8. So this is definitely a way larger effect than what you observe for drugs that are prescribed every single day.
Well, and I would also argue that you have people who are pre-diabetic, and so you're not going to see that much of a drop in an A1C in those patients as if you took someone, everyone was newly diagnosed with A1Cs of 11. You're going to see a lot more dramatic change, as I do in my clinic. Of course, I mean,
to observe a change, you need to have room for change. So in this case, because they are not that far from what HbA1c should be at, well, of course, they don't have exactly that. The room for change is not that large. And despite that, you observed an effect size that's at least twice what you observe for the drugs that are prescribed every day.
Exactly. And one more thing I'll add to this, and we'll get, I'll finish running through the data, but it's a good point to comment that this was despite deprescribing diabetes medications, which were the things that were initially presumably holding the HbA1c down. So the 1.1%, while it's at, you know, the 95% confidence interval equivalent for most diabetes drugs, this is despite the fact that the diabetes drugs were actually being removed from most of these patients. So that's pretty astonishing. So this is underestimating the effect, nevertheless.
And blood pressure meds being removed and other medicines being removed.
Solid blood pressure drop means 17 millimeters of mercury, which is more than any other diet I know. Trigs dropped by 60 milligrams per deciliter. And then one of the kickers was that we used the American College of Cardiology and American Heart Association 10-year risk score for major cardiovascular events. And the relative reduction in risk was 44% for having an event over the next 10 years, which is an astonishingly large reduction. And for absolute values, because you should always report absolute with relative, initial starting risk score was 9% and it dropped to 5%, which equates to a 44% relative risk reduction, which is an astonishing drop. So these people were not only losing weight, their blood sugars were improving, they were coming off medications, their cardiac risk scores were improving, and because medications were being deprescribed, not only were the employees winning, but this self-insured company was able to save a lot of money. So the annualized cost savings from medical deprescriptions was about $4,000 per patient per year, equating to about $45,000 in this group. And that's only going to be expanded as the project is ongoing and is increased in scale. And that doesn't account for improvements in worker efficiency and acute care needs. So,
and I would add in, you know, the quality of life issues, right? Of having happier workers who are happy that they've lost 38 pounds and they're, you know, or 58 pounds, and maybe they're more presentable when they go out in public and they feel more confident doing sales or things like that. And so that's a huge factor that people don't talk about, because a lot of the companies that I've talked to, you know, HR people in particular, they'll say, we're just crossing boxes off saying, yeah, we tried this, we tried that, we tried, and they don't really expect good outcomes. So when you see stuff like this and you're self-insured, that's where the market is really open to save money as a company.
I guess what I'm saying here is that, like, yeah, there was a 38-pound weight loss per person, 1.1% HbA1c reduction, 44% reduced risk of heart disease, or 10-year risk.
And let me just.
This is I was just going to capitalize on what Brian was saying or reinforce that all of this is kind of underselling the benefits, because the benefits would have been larger, you know, if patients weren't on medications to begin with. There are cost savings, and we're not quantifying things like improvements in worker quality of life, which has knock-on effects on their family's health, which has knock-on effects on their work efficiency, all these things that we have not yet quantified.
I just wanted to emphasize that this is actually opposite to what you observe with many other interventions that also improve health. What the rule is that improving health and health markers costs money, typically a lot of money. So it's actually rare to have an intervention that saves money and improves health and health markers. The model that what we are used to observe is, okay, you can improve someone's health if you spend a lot of money. And this is, you can improve someone's health and save money. This is not something that you observe every day in the medical literature. And this is not something that decision makers are used to see when deciding if you should spend or not, invest or not in a specific intervention. So again, I just want to emphasize, because I think it can get lost in the discussion. This is not business as usual. Business as usual means you spend a lot of money and you improve mildly some health markers. This is, you stopped spending a lot of money and improved massively lots of health markers.
Yeah, it's incredible, because, you know, the other big thing is that, you know, the big kick against low carb diets, like, oh yeah, you lose weight but you're gonna have a heart attack, and they say, well, they decrease their risk, right, based on our guidelines. And so that's a huge issue too, right? Because we're looking at a lot, you know, someone one of your employees has a heart attack, then you got to replace that employee, and the cost of that, the cost of, you know, the emotional stress on the staff and all that. So it's a huge deal, like what you've accomplished. And so it's exciting that we could save companies money and make the employees healthier, right, and more productive. And that's a huge issue that a lot of people don't really recognize. Let's let Amy jump in here. Amy, tell me your experience with this whole thing, dealing with all these characters.
Well, it's been fascinating. I'm going to push back on something that Dr. Soto just said in terms of this is not business as usual, because anybody that, I come at this not with a medical degree, but with sort of like as somebody who had a BMI of 64 at one point in my life, like I understand, and along with all the people that were in our program, understand what it feels like to fail at diet after diet. I tell every client and patient that I work with, I literally dieted my way to over 400 pounds. And so we all know, all the, what the data is, we intrinsically have learned about all that failure. And so to be part of this, it's been an incredible honor, right? It's really, and it is why we show up and do this day in and day out. It's not about, the numbers are important, and I get it's why it's important to add this to the scientific literature. But, when we hear people say, like that they're off of their medication, they just want to be off of their medication so desperately, and they want to lose weight so desperately, and they have been trying so hard for so long. That's really, to me, is just incredibly powerful. So it's been an honor.
Yeah, and you represent the human side of this too, and that's the important thing. It's not just saying, okay, here's a program here, just eat these things. I mean, there's so much involved with, and especially, obviously your people had really high BMI starting out, so there's a lot of emotional, food addiction, all these other things we got to deal with. So, having your app, having reinforcement. And I can't even remember if you did Zoom meetings with the whole crew at the same time. And, those things are so powerful, just that human aspect, because a lot of the people we're seeing and the people who are your critics are the ones say, here, just take this drug and you'll lose weight. You don't need to do anything. And we're not figuring out how to have long-term success, because the GLP-1 agonist, for instance, when we look at the data, if they don't change lifestyle, that weight comes right back when you stop this really, really expensive med. So what you're doing is giving them tools that they'll remember 5 years from now.
Yeah, the emphasis is really on lifestyle, and teaching them about their relationship with food, while also addressing the medical piece of it and the medications and all of that.
I have one question for Dr. Soto, actually, before he's already got his hand raised. I got one question for him, but before we do that, Brian, you mentioned the GLP-1 agonists. In fact, 2 of these patients were able to come off these GLP medications and still lose weight, right, and still maintain their A1C down. So, we had some people who are on GLP-1 drugs, and we were able to even get them off. So, we're very favorable on those drugs in our clinic, but just so you know, some patients are able to make lifestyle changes and come off. So, but Dr. Soto, I wanted to ask you a question, because you had hinted on this in our discussions in the past, and I wanted to pick your brain about it. The AHA and the ACC, they task us with calculating a 10-year risk, but there are so many elements of that risk calculation that aren't really covered. And one of those is, insulin sensitivity. And one of the points that you had made to me was, Tro, look at how much HOMA-IR changed, which is the way we kind of estimate insulin sensitivity, and notice how it's not really reflected. So can you just talk to me a little bit about these risk calculators and how we use them as clinicians, and maybe what they mean and what they don't mean?
It's a whole topic. Clinical prediction and clinical classification, it's a whole topic. And something I really try to emphasize to internal medicine.
I know this is right up your alley, man. I'm giving you a layup. I know you love this topic.
It's absolutely. Something I always emphasize to the internal medicine residents I teach and oversee is that clinical prediction calculators or models or scores or whatever you want to call them are useful tools that, as any other tool, are fantastic if you use them in the right context. And to put a dumb example about this, they are no different than having a toolbox and choosing the right tool for your task. Let's say you have a hammer, but if your task is to cut paper, the hammer is just an awful tool for that. This does not mean you shouldn't own a hammer. This does not mean that the hammer is a useless tool. This does not mean that the hammer is better than any other tool. Of course, you should opt for the scissors, etc., etc. Well, the same is for risk scores. The problem here, and something that most people forget or oversee when they use or apply these scores, is that they were built within a very specific context to answer a very specific question. So it is not rare to find a clinical prediction tool that cannot or should not be used for a specific clinical question. And this has been observed many, many, many different times for COVID mortality scores, for liver cirrhosis, risk assessments, and this also means that a clinical tool that was developed for a very specific population won't necessarily reflect or accurately predict outcomes for a different population. And how this comes back to our context, most cardiovascular prediction or risk calculators were built with data from people who did not follow a low carbohydrates diet, who were following typically a Western diet, high in processed foods, high in sugar, low in fiber, etc., etc., etc. And therefore, if you try to apply or you try to predict risk for someone who follows these diets, well, okay, you can expect the accuracy that has been published. But if you are trying to use these tools for someone who comes from a very different background to the population that generated these risk scores, you won't get accurate predictions. And this is also relevant because here is where clinical judgment really stands out. And it cannot be replaced by an algorithmic, statistically derived tool. It does not matter how fancy your statistics are, and don't get me wrong, I love fancy statistics, but it does not matter how elaborate they are, how modern they are, they will never be able to replace clinical judgment. And nowadays it's super fashionable to say artificial intelligence and words like mouthful terms like artificial neural network. Well, come on, I mean, natural intelligence and natural neural networks, basically our brains, are still unchallenged for certain tasks. So clinical judgment is this, for Marvel fans, this spider sense on the back of your head, like, nah, whatever the scientific literature is saying does not necessarily apply to this patient. And this is why, despite it's useful to have these statistically derived tools because they allow us to, yes, make some accurate predictions in some groups of patients and to compare different interventions, you should always remember that as any other tool, they will do an awful job if you choose the wrong task for them.
Can I add to that a little bit, just to Dr. Soto? So one of the things that I 100% agree with you, but one of the reasons why we included this data was because it also helps doctors understand the language, right? People get, this 10-year risk language. So now when they see the risk reduction in their language, right, they get, hey, this isn't, they get over the dogma, they get over the, like, these are results. These are the results in the way you should know them, right? These are the guidelines and what they're asking of you. So it helps communicate to doctors, hey, maybe, and Diet Doctor had a great video on this with Brett Scher just today, where they said, it's not, it's improving cardiovascular risk factors. So don't think that you're going to die skinny or, going keto. the other thing I wanted to bring up was there was a great study from Kaiser showing that this risk calculator was off by 500%. You know, I don't know if you saw Marianne Damasi's commentary on that, but absolutely, you know, so yeah, but we did calculate it. We were surprised to find it. You know, I don't know, you know, Nick, if you saw any other data that you found surprising here.
In your data set, in this data set?
Yeah, or compared to, you know, other data sets. I know, because we're not the only group to show, you know, a reduction in costs and improve. You know, the David Unwin's data set showed that they run their diabetes, they cost the least in the NHS system, right, when it comes to managing diabetes. So that's David Unwin's group. And we've built on Virta's group, which, you know, I think Virta basically shares in cost savings now in some cases.
Yeah.
They can so reliably apply metabolic health, you know, that they're taking that risk.
Yeah, I mean, I guess you just highlighted one of the real strengths of this study is that it's, what are you going to call it? A medical technical triplicate? That this approach, some form of it, focusing on metabolic health with low carbohydrate, nutrition, education, in a population of people with, you know, metabolic disturbances, metabolic syndrome, obesity, diabetes, it's being implemented all over, you know, well, in different countries, including David Unwin. And now I guess this is at least the third time that there have been results somewhat like this, which is kind of astonishing because, like Adrian said before, this is not business as usual. This is, you know, win-win-win. You're saving money on healthcare costs. People are improving their health. And the fact that multiple different practitioners are able to pull it off with somewhat similar approaches suggests to me, more so than any single off report ever could, that there's something here that needs to be pursued at greater depth. So,
yeah, in selecting your patients, what was a big factor? Were you looking at patient motivation or their ability, or, you know, because, you know, a lot of these programs, if everyone's kind of forced to do the Biggest Loser program at their work, you know, a lot of people aren't even they're checked out, they're not really into it. But, you know, did you select somehow that way someone who's mentally in a spot where they really want to change their life?
So I can tell you, we were limited by who we could see. So we accepted applicants. We reviewed each applicant by hand, right? And we do assessments for readiness to change. We do assessments for, you know, we do multiple assessments. We look at, you know, if there's any binge eating or other factors. But bottom line is, you know, we were looking to see who we believed we could have the most impact on. And I think really, you know, if you have the most severe disease, you're most likely to benefit, right? So I think we try to mix the willingness to change with severity of disease. And it was literally a one-by-one approach right now. You know, we're building the Roadster. You know, that's the way I kind of, you know, that first pilot, we've now expanded it to 70 patients. You know, we were building the Roadster. And now it's, you know, so yeah, we're refining that process now.
Yeah, and I think you had to demonstrate that there was a benefit, you know, because HR can't have 5,000 patients doing this at once, right? So they had to figure out if it was a big flop, then they wouldn't be interested.
No, we couldn't. They wanted it. The company was, so this particular company is so highly invested in their employee welfare. I've never seen it. They have CrossFit gyms, dietitians, personal trainers, physical therapists, clinics on site, a pharmacy on site. They've done Weight Watchers. I mean, this is a model company. So when they came to us and said, we've done everything, we want you, I was like, wow, they're, you know, they've really done everything.
Well, that's pretty awesome from that standpoint, because a lot of these companies, I know a lot of the tech companies, they have vending machines with Coke and you know, chips and crackers, and people get them free. And that's one of the perks of working there. But then they all gain weight in there. Like, one of my best successes I've had is one of those guys who works for these big firms. And I said, okay, look, we just got to make some changes. And he crushed it, like, very easily. It was a ridiculous. Like, he was one of those guys who goes, oh, I lost 6 more pounds. Oh, I lost 8 pounds this week. Oh, I lost 4 more. And was just really giving up the soda and the chips and the processed foods. And he killed it. So a company like that, that's already health focused, to have that, and that just speaks more to what you accomplished with them.
Yeah, so the company was perfect for us. I mean, we did our due diligence, and what they asked us was great. And we actually, here's the thing, if you look at the literature for employee wellness programs, it's been a big flop. Meaning, like, generally when they spend the money, they don't get it back. Just like Adrian had said, Dr. Soto had said, he's like, generally they don't make the money back. So my biggest concern was, not that I wanted to make them, but I wanted to have an effect, and I wanted to be able to quantify the effect. Every patient had a scale, a blood pressure cuff, CGM, Keto Mojo. We were literally watching everything. We checked labs very regularly. Basically, we wanted to verify the impact of what we did, because we wanted to know, are we having an impact? If we're not having an impact, I want to move on. I want to impact people I can have an impact on, and the company should want to move on. So the big limiter has been our clinic. The company is like, just come help our people. So yeah, we started with 12 to see if we can have an effect, and we had an effect, and since then we've expanded. Maybe just, I see Dr. Soto there waiting patiently, so we'll get to him. And then I wanted to talk to Amy about, what it was like with these people. The way we affected their lives was so heartwarming. I can't, like, that stuff is so important to discuss. Dr. Soto, you first.
Actually, what I wanted to say was exactly that I really want to emphasize, because this can also get lost in the woods when interpreting this data and these results. This is what you would typically call a mixed intervention study. And it would be a mistake to think that the intervention in this study was, go and make low carb. The intervention here is patient education and patient empowerment. Is, of course, a crucial part of that is restrict carbohydrates, get rid of junk food. But the real intervention, what's driving these amazing results, it's not only a low-carb diet. It's really patient education. And it's having this context or this environment where you can get instant replies to your questions because you have a direct communication channel with Tro's clinical team, and where you have this group support, and when you have all this material to learn, and when you have, it's not handing a list to someone, you should avoid these foods and that's it. The intervention here is not a diet, is this team, multidisciplinary intervention aimed at empowering and educating patients. So one should not expect these fantastic results just from dieting. It's really about how the real treatment, the real thing is to educate patients so they can then make responsible, and they have the necessary tools to make of this a lifestyle and not a diet. And in other words, the intervention here is really Amy and Dr. Tro's team, not a diet. And of course, you really, really shouldn't expect these amazing results just from a single piece of the whole puzzle of this treatment.
Yeah, and it's putting a whole team together, like someone who could really connect with the patient, or is caring, checks, sends them a message, say, hey, how are you doing? We're thinking about you today. Whatever, those little things that help people stay on track and get on track. And Amy, I know that's a huge thing for you too, because you've been through it and you know what these people are going through when they try to change lifestyle.
Yeah, it is really an immersive lifestyle program, and I think you're absolutely right, Dr. Soto. It's you can lose weight on any program, you can improve your health markers on just any diet, but yeah, we really approach this. We don't even really talk about weight loss at first. It's really about how to address your hunger. Why are you hungry? And then once that hunger is dialed in, which, as we all know, is low carb, helps so much with that. Then we really look at the lifestyle. We look at issues like food addiction and stress and mental health, and real-time contact with one of us has been really, I think, incredibly powerful. And, I mean, we see these results often, but seeing it in a collective group like this was incredibly powerful. And, Dr. Norwitz talked a little bit about sort of the impact on their family, but, countless numbers of these people have talked about how their spouses have lost weight, how their spouses have gone off of diabetes medications. And so it's been really powerful. When I remember early on, we had so many applicants, and one thing we haven't mentioned is that the most of the people in this cohort, in the first cohort, are in a part of the country that is a very well-known culinary capital. It's a city where people flock to because of their food. And so it was even more difficult for some of these people to deal with
Amy, we just have to let people know, because they don't understand. We called local bakeries. We found out local places to eat. We talked to the dietitian at the local hospital. I mean, we talked to 5 different doctors that manage these people in the local health system. I mean, we literally embedded our fingerprints in their community and the families. I mean, when we talk the average patient, we were just kind of estimating the amount of touch points they have, their scale, their blood pressure cuff, their ketone meter, their blood sugar meter, using the app, messaging, texting. There is somewhere between 300 to 500 touch points in a 6-month time frame, right? Between our office and them, right? In some way. So it is a very, I don't know, it's immersive, I don't know how to describe it, but, we've done a lot of legwork, and we're doing more legwork. We're going and we may be visiting the corporation and doing, kind of local presentations. There were posters, there was table tents, there was,
we want to address like what they're serving at their conferences. Like, why are there cookie platters at conferences? Why it's just mixed messaging between, and this I think with people all over, not just at this company. There's like every conference they feed you 12 times every hour. And so it's really been, we're trying to kind of really work our way into everything that might be a challenge. I had one woman who joined the cohort, and she said, I am praying to do well on this plan because I want you to be able to do this for other people in my company so that you could help my coworkers. So she was motivated by both her own health, but also so that she could bring this to her coworkers. She was so just motivated to just do well.
We had another patient, who, it wasn't all a cakewalk, and, there was some adversity also. We had a patient who went from an A1C of 7.5 to 5.5, and her blood pressure started to come down, and she started to get a little lightheaded, and she reached out to us, and we adjusted her medications basically in real time. She followed up with her doctor, because I said, look, we're going to change these blood pressure medications. This is what we do in real time. We can adjust it, but we're a team here. So go back to your doctor and just let her know, what's going on. So if any further care is needed, you can, we can help, and they certainly can help as well. And she went back to her doctor, even though she's now off of diabetes medications, A1C is in the normal range. She's not even pre-diabetic, normal, down 30 pounds. And her doctor looks at her and says, you will always and forever be a diabetic, and I cannot take you off any of these medications, even though her blood pressure had decreased. So, we have to navigate caring for these other people in the, who have doctors that may be a little bit dogmatic, or who may be, it's not always, wasn't always a cakewalk, but, the patient got the care they needed. And sometimes it's, those human elements don't come across in a paper like this. The struggles that patients face, the things that the things that you don't see, like one of these patients on the app shared with the fact that she went down with her family, like in a carnival. She went down with her grandkids on a slide, and she would have never been able to do that. I mean, you aggregate this data, and it looks great on paper, and it looks great to do this, and this virtual stuff, and everybody saved money. But sometimes we forget, like we got a message that, one of the patients who came off insulin, her kid started to lose weight, who had struggled with anxiety and weight for a long time. a husband who was diabetic, came off of his diabetes medications, hadn't seen the doctor in over 2 years because of the COVID pandemic, and went back and was able to, come off all of his medications. So it's these like small little human elements that, I don't know if it ever, it doesn't come across, but it's like, that is the true beauty.
Yeah. And that's the amazing thing is it's not part of the study, right? But, I did this thing with the Vacaville Fruit Company. They had me come out and do, a similar thing with 23 women, 17 didn't speak English. And the impacts to see them when we did our Zoom meetings that their husband lost 28 pounds, he's off his diet, like all these people that weren't part of what we were doing just by being exposed to it or having the wife cook different or the husband cook different at home, totally impacted their family, their communities. And it was just amazing what they did. And even the stores in the neighborhoods would stock other things that they would want, like fresh eggs or low carb tortillas or whatever. So it's pretty amazing, like just outside of what the study shows, because darn well, a lot of these people that were doing well in their program, they're influencing their husband and wife and partner, and kids, and you're making a bigger impact than what we could show on paper.
It's interesting because I remember when I first started low carb, and it was the only time I had ever, of all the thousands of attempts. And the thing that you hear over and over and over again is, oh my God, you're going to have a heart attack from all that butter and steak. And, sure enough, every patient that has come to us has said something similar. And that's why we take labs periodically. And I always tell people from a health coaching perspective that, just keep your explanation simple. Don't use the word keto. Just say I'm avoiding sugar and I'm eliminating processed foods, because no doctor, I don't care who you are and how stuck in dogma you are, no doctor is going to argue with that, right? So just don't use the K word for a while. And then when you
totally
show how successful you are, you will let your success talk for you. And then you go in with your labs and you show them, and just keep it simple, keep your explanation simple, and then just let your success be the proof that you need.
That's a huge deal. That's a huge deal because I know a lot of people they get this evangelism and they go to their doctor. I'm keto. I'm doing, and the doctors freak out. If you go, hey, I'm just cutting out processed food. I'm watching my stress. I'm getting more sleep and I'm exercising more. They go, oh my gosh, you're brilliant, but you're doing the same thing.
Right.
But it's all semantics and how you approach it. And if you say, hey, I just stopped eating cereal every morning or whatever it is, and it's pretty amazing how there's this, just like what you're saying, Tro, it just rings with me. As a matter of fact, I saw one of my patients dragged in his best friend yesterday. The guy's around 450 pounds, maybe, big dude. A1C is 6.4. His triglycerides are 826. And we watched, and I was looking at his old labs and I just see it going like this, his A1C and his doctor. And I said, are they doing anything about that? Did they talk to you about lifestyle or diet or anything? He goes, well, he put me on a medicine for my triglycerides. And he said, once I get over 6.5, they can start treating the diabetes, but they can't do it before then. I'm like, oh my goodness. Then your life insurance, you know what? You're like on the, right? You're already there. So it's just amazing, this mindset that people have. Like once diabetic, always, you're never going to come off your meds. And it's, I can identify because I used to be there to think it was impossible to come off insulin. Then we see people do it and you're like, wow, okay, this is pretty amazing.
So something I want to add on that topic is that there is this small critical care handbook that I came about when I was in my residency. I think it's Paul Marino's critical care handbook. And at the very beginning, it has like 7 pearls of wisdom for your medical practice. And it has, like the common things, rare presentations of common diseases are more frequent than typical presentations of rare diseases, et cetera, et cetera. If you hear how it's think horses, not zebras, what we're used to. And one of them says, if whatever you're doing is working, keep doing it. And if whatever you're doing is not working, well, then reassess. But it is amazing how this is perhaps a truism, and it's something that it's almost obvious or self-evident. But people eventually will stop arguing with whatever is working. So, however, before they reach that point, they can become an obstacle. Because if you, as you say, if you throw around the K word and you start hearing every single day, you're going to have a heart attack, you're going to have a heart attack, and people start bringing you these nonsense paper they found on the internet saying you're going to have a heart attack, they become an obstacle for something that could work. I think it's a smart move to stay with, I am avoiding sugar, I am avoiding ultra processed foods, I am focusing on real whole foods, because no one will argue that, and then they will stop being a potential obstacle. In the end, everyone will ask you, what did you do? You know, like how no one argues once they see success, but they can become an obstacle before that happens.
Yeah, you have to look dumb for a few months, I think. You just have to accept that people are going to say you're crazy. No wonder you weigh so much. You're eating steaks. That's your problem. And then when they lose weight, then they say, wait a minute, this, you know, then people, there's nothing like a testimony. That's what's amazing. You know, all of these, well, 10 patients you ended up with, or they're a testimony to their families. They're a testimony to other people out there who've been told by their doctors, you can't reverse this condition. It's chronic, irreversible condition, you know? And so, yeah. And when you start thinking about metabolic health and how critical it is.
I'm just hoping that, you know, when we reanalyze, because we have cohorts 2, 3, and we're planning on 4 already, and we have an idea for a control arm, which is people who we cannot see, who just have access to our app, to see if we can measure their outcomes in some way. But, you know, bottom line is we're going to do usual care on multiple more cohorts, the way we provide for people medically. I'm hoping that we can make this into a bigger and bigger project. And I'm hoping that Nick Norwitz doesn't burn out in between now and then. I think he's getting a migraine right now just thinking about cohorts 2 and 3. Oh, you're muted, so.
I was reflecting on, I just came from an ED, emergency department clinic, and there was just a big crate of free graham crackers for the staff. And I was thinking about that and rubbing my temple from frustration. That's what I was rubbing my temple
Yeah,
about.
I was going to bring that up. I saw you had posted that. And that's what's crazy. If you go like Doctor's Day, Nurses Celebration Day, it's all donuts and cookies and the worst thing they could possibly do for their staff, you know. And, you know, one of the big leaders in low carb, he worked hard to get sodas taken out of the restaurants there at the hospital. But then they put them all back in and go, let's celebrate, everyone, it's back, we can have this. And you're like, wow. Like, do you not care? Like, do you not see what's happening with the night nurses? Do you not see what's happening in your hospital? It's a disaster.
Yeah, the hospital food is really just
something. Exactly.
I saw one patient getting fed, like it was like a really nasty bran muffin, and then there were eggs, but the eggs looked like cotton candy. This morning, we walked out of this guy. I'm like, the saddest part of that interview is those eggs. I swear they're just cotton candy. It's like it doesn't there's like a juice in those little cups that you just peel.
Well, go to the doctor's lounge. I remember. I could tell you exactly. It was like coffee with all kinds of sugar, and then they had, you know, sandwiches, but there was donuts and bagels and
there's DiGiorno's for breakfast.
Yeah, it's incredible
for breakfast. And in the salad, the fresh colorful salad, there's Fruit Loops. And like
I typically say, because my hospital is across the street, Mexico's Oncology Institute, is every time I see one of our patients is served orange juice with hot cakes, with every residents already know what I am going to say is, do you think our neighbors across the street have cigarettes for breakfast? Do you think if they go down to the other day, I don't visit frequently the staff cafeteria in my hospital, but the other day I went after a while, and my menu options were 4 tortillas, 2 slices of bread, pasta with white rice, with a chicken breast serving, 2 choices for dessert of Mexican sweet bread, fruit, and juice. And of course, I could only eat the chicken breast serving. And when I asked just for the chicken breast, the kitchen staff looked at me weirdly and said, like, are you sure? Yes, of course I am sure, because it's and I am gonna lecture, you know, in the middle in the waiting row for when everyone wants to eat. But it also is so frustrating to see, because I haven't added the irony here. The hospital I work in is the Nutrition Institute in Mexico. So of course, I mean, it's ludicrous. It's in the end, these will be seen I hope that within my lifetime, these will be seen as serving cigarettes in the cafeteria for the Oncology Institute.
It's pretty insane. The other day I went to, it was like Waffle Thursday. They were out of hard-boiled eggs, which is usually the only thing I can buy. And I just hadn't eaten because I was up since like 4 and running around. So I'm like, all right, there's some walnuts. I'm just gonna get those, raw walnuts, whatever. And the seed oil people can attack me for that, whatever. But I bring a cup of walnuts and I'm gonna check out and they're like, you can't buy those. And I'm like, why can't I buy these? They're like, those are topping for the oatmeal. I'm like, so I need to have oatmeal under the walnuts in order to purchase these walnuts? And they're like, yes, you need to buy the oatmeal with it.
It's
That was like literally the only low carb thing was the topping walnuts, and I wasn't allowed to buy them.
yeah, it's amazing.
That's
Amazing
crazy.
stuff. You make it such a challenge to do these things. So yeah, I'm super excited about what you're all doing. And come on, California, San Diego, some of you companies out there, give me a call. We could do this thing. We'll get 14 patients and we'll drop their A1C by 1.4 and weight 42 pounds just so I could pick on Tro. Someone's going to help me out do this.
We would love the collaboration and or competition. But here's the thing, in fact, if we had a little bit of, I'm thinking about like, how do we tell, because we don't have a control arm. That's one of the issues that I'm facing. I'm thinking about how do we show that this composite endpoint is effective, and
Oh yeah, we could do that. Yeah, that would be fun actually.
Who would fund that? But Dr. Soto reminds me, I don't know if you remember the trials for, and Brian, maybe you've seen the literature that I remember, this like 10-year-old literature of central line data, central lines, and they would show that, they didn't know what it was, but if you did a shotgun approach of, wiping the area down and not putting a femoral line, like if you did a shotgun approach, it was better than nothing, right? And that's what we have right now. But what I'm thinking, what we need is more specific data. And maybe one day, you guys, between, the two smart people in the room here, Dr. Norwitz and Dr. Soto, that's not you and me, Brian. So,
Yeah, I'm just a doc, man. I don't know all this number stuff.
Maybe they could design a trial that could be more impactful,
Or you could try, yeah.
No, something I want to say was that now I have mixed feelings about these ideas, because the first time I heard this was from Sarah Hallberg, and she said we need less randomized clinical trials. And to be honest, the more and more I think about it, the more I agree with her. I mean, of course, she was a fantastic researcher for low carb, but her point was, in the end, yes, you can have head-to-head dietary interventions. You can compare head-to-head dietary interventions. And some people will stubbornly refuse any dietary intervention. In the end, it's not so much about learning what wins against what, which form of diet wins or is the overall champion. In the end, the question is clinical. What is the best dietary approach for the person that's in front of me that I am supposed, who I am supposed to help? In the end, it's an individual question, and not a yes, of course, we can publish papers and we can fight on Twitter and we can, yes, this is the overall best diet. And it's irrelevant if my next patient says, yeah, I don't want to do that diet. So, okay, end of algorithm, You know what?
Exactly right. Exactly correct.
I want to do a trial versus 1 milligram of Ozempic. That's what I want to do. I would do a trial of you in our clinic, plus or minus meds, if we think it's necessary, versus Ozempic. I'll do that trial.
That's the other thing, because one should not make the mistake I was trying to emphasize earlier. All these trials are mixed intervention trials. All these trials control for diet. All these trials provide patient education, because of course it would be unethical not to do so. So you shouldn't expect these good results that have been published for these drugs from the drug alone, because all of them are mixed interventions too. There is this fantastic, well, of course, I would be biased against it, but there is this paper that shows that 90% of the physiological changes that are associated with bariatric surgery are already in place the day of the surgery. Because bariatric surgery is also a mixed intervention. It's not just a surgeon in the OR. It's also a diet team. It's also psychological assessment. It's also basically the same intervention that is in this paper. So you shouldn't expect this from a knife or from a pill or from an injection. It's a mixed intervention trial. Now, that said, and this is something I discussed actually when I was defending my thesis, Rory Holman is it's one of the biggest names in diabetes. He basically inherited the UK PDS and he directs Oxford's Diabetes Center. And there was a point in my thesis where we had to discuss the UK PDS. And something we agreed on was we need to revisit the UK PDS because this was the first trial that showed that medication reduced certain outcomes for diabetes. My life's dream would be to repeat that trial. The UK PDS had 3 arms that do business as usual arm, insulin or insulin secretagogues arm, and metformin. Well, because diabetes healthcare has changed so much, the new arms should be, the dietary arm should be, of course, low carb. The drugs arm should be, if you want, SGLT2s, because no one uses, or insulin secretagogues are on the low, and the other arm should be business as usual. And if you want, but I am convinced that would change clinicians' mind on, that would emphasize that the treatment for diabetes is a dietary approach, more than a drug approach.
I think if they redid the Accord trial right now with SGLT2 drugs and GLP-1 drugs, that aggressive A1C measure would be better than not aggressive.
In other words, what we need is an SGLT2 against low carb, against insulin secretagogues trial.
Yeah.
And of course, we expect what would happen. So to go back to the original point, I want and do not want at the same time a randomized clinical trial involving different interventions, because in the end.
Yeah, and the other thing, the other issue really is like the company you worked with was self-insured. So the problem is all the med arms are going to be way more expensive. It's going to be way more expensive than the dietary intervention is. And from a cost perspective, you're looking at cost savings from a company standpoint, right? It would make a huge difference in the numbers down the road. So
that's a very important point, because these kind of mixed interventions of patient-focused, dietary-based, with community support interventions are spherical in the way of, from whatever you look at them, they are beneficial. And you cannot make the same statement for drug-based approaches.
Yeah, and Amy will tell you the same, that we all failed all kinds of diets, right? It didn't work for us. So we didn't know the right tools forever. So if you give me a drug that makes me lose weight, which it will, but if you don't learn that you can't eat cookies and donuts all day long, and you can't, eat at 10 o'clock before you go to bed, you're never going to, once you come off the med, you're going to gain that weight back. You're at a life sentence basically, unless you make some lifestyle changes. So you have to make this lifestyle changes. So it may be an argument that you have an arm with both of those things and see what happens, and it may even be unethical based on what your study shows is not to intervene, to have an arm of people that you don't intervene with, because you decrease cardiac risk significantly. So is that ethical to do that at some point?
Yeah,
to get to that point.
That's something to think about. I'll give everybody a chance maybe to give their just like last little parting words. This has been a fascinating discussion. I'm just so honored to work with all of you guys. I'm honored to have such an amazing team with Amy Eiges, Brian Wiley, Taline, Tori, Esther, Myra, who's now in med school. It's really great to have people, Nick, like yourself, and Adrian, that really can support and elevate some of these clinical works. And so I really appreciate and thank all of you guys from the bottom of my heart. I don't know which camera is on, but from the bottom of my heart. And Brian, certainly being a mentor along the whole way. Next time, Brian, you can join the trial.
Yeah, I want to do it. I want to do it down here. Come on, San Diego, let's do this thing. Amy, what do you have to say about this thing?
Yeah, no, well, it's an honor to work with Tro. I have talked often and fairly publicly about, being subjected to thousands of quote unquote experts over the course of my lifetime. And, the work that I do feels like redemption for a lot of wasted time and blood and sweat and tears, and really just getting awful advice for a really long time. So it's just an honor. It's an honor to work for Tro. So thank you. It's my academy.
Dr. Soto.
I am grateful for the opportunity of adding whatever value to this project. I have to confess that the first time I saw the data, what I told Nick was, well, this actually, the effect is so large, you don't need statistical tests for this, which is perhaps the strongest statistical argument. When differences are so large that regardless of what you use to analyze those data, you would get the same result, well, that's a meaningful effect. So I think, nonetheless, and as we were saying before, because clinicians and decision makers sometimes need a number and sometimes need an argument in the way they are used to change their minds or their practice, it's of course relevant to produce these studies and results. And I was so glad to participate and to collaborate. And I think that, I hope that this can be replicated in many, many different places, because I cannot think of a country in this planet that does not need or would not benefit from improving health, reducing the costs, and adhering to a more holistic, multidisciplinary way of practicing medicine. There is not a single place on this earth that wouldn't benefit from that. And I think it's, I'm grateful to collaborate in one of the arguments in favor of that.
Yeah, I echo everything everybody said. I don't even really know where to start. I'm as you all know, by far the most junior person here, and often the most junior person in any room, podcast, or whatever that I am present on, just because of where I am in my career stage. And yet over the past few years, which sounds like a short time, but feels like eternity, I've been able to build a lot of not just professional networks, but friendship networks, and find what I think will be the nucleus of purpose in my career, which is, wow, it's frustrating to walk in and just see a crate of graham crackers. Also very, a very positive feeling. So there's part of me that's just chomping at the bit to get going and doing the kind of stuff clinically that you're doing. Just gotta, that's going to carry me through the next little while, and then hopefully through my career, so I don't get burned out, and so that I have, always something meaningful to do. Because I think, like we tried to cover here, especially you guys, Amy and Tro, there's a human aspect to this, and it's really exciting to be able to fuse research with that human aspect, which I feel very privileged to be somewhat in the place to do. So yeah, thank you for involving me.
Yeah, and I want to thank you all for your pioneering work here and for opening the door for a lot of people, because I see this for direct primary care docs out there who really want to impact their community, really want to help people. It does open a door to say, look, we have data, and your critics will be there. They were going to be your critics before they made up their mind before they looked at the study, and that's the problem. Is so many doctors are so focused, and what they know is true, and they're not going to change. And so all we can do is reach the people we can. And so by showing numbers like this is pretty dramatic and it's pretty amazing. And I hope employers out there are looking at this saying, hey, I want the best for my employees. I want the best employees, that are focused, mood, energy, staying healthy, not calling in sick every week, being able to go up and down the stairs if they have to, and then building that camaraderie in the community, how critical that is. And so that's why what you're doing is so important, really is, because other companies are going to sit back and go, okay, we could save money and have better employees and healthier employees and enjoy each other's company more and not have so much conflict. Like, no one wants hangry people around, like that food coma after lunch and all that kind of stuff. And so, yeah, it's really amazing what you're doing. And I think there's a lot more studies to come and case reports. And the other thing I would tell people listening is, a lot of people will discount these as anecdotes. They'll say that's just an anecdote of 10 people, those kind of things. But those are 10 lives. Those are 10 people out that are impacting their communities, and they're better, and they've lost tons of weight, and they're not going to be a drain on the Medicare system, which is sinking very quickly. So the only way we could really do it is prevent illness and prevent all these constellation of metabolic disease. So Tro, since you're the guy, man, I'll give you the final word, and we'll cast out here.
Yeah. Look, it's been an honor and a pleasure. It's just, this is our mission. I told Amy, we're working on our, we're working on clarifying exactly what our mission is. It's end diabetes type 2 and end and reverse obesity in as many people as possible. We're in 50 states. We just hired another doctor, Dr. Laura Buchanan. We're looking for another health coach, and this is just exciting work, and it's hopefully we can have a meaningful impact. And we are building on Eric Westman, David Ludwig, Sarah Hallberg. We're building on all the work that Verta showed this. They were the first group. David Unwin was the first group really to show this. And we're just building on top of that and trying to expand on top of that and springboard and get the message out. And we're working now with the SMHP to aggregate that data, and so we can have every single doctor that has metabolic health training go to their local employer and say we can do something. So it's exciting work, and I'm just so it's nice to have allies. It's nice to it's really awesome to work with all of you.
All right, everyone, you heard it. Great paper. Hey, we'll put a link to the paper there, and for people who are I have to read it because it's complicated for me. But it was called "A Company is Only as Healthy as Its Workers, a 6-month metabolic health management pilot program improves employee health and contributes to cost savings." So cost savings companies, that's a good thing to do and make your people healthier. So, hey, everyone, thanks for listening. And we know you got something out of this, but we'll put a link to the study, and you can read it yourself.